The information that I'm going to give you today can be found on my web textbook, www.pdmillerswebtextbook.com, which is a new initiative in education because, in my opinion, textbooks in the future are going to be obsolete. Furthermore, if you write a book and you want to add information, you have to have a new edition. With my web textbook, as more information comes out or information needs to be clarified, all I have to do is to change it on there in about 15 or 20 minutes and then redictate it. I'd like to thank Millennium not only for allowing me to make this presentation, but also for partnering with the Miller-McIntyre Periodontal Prognostic Index to help focus on treating periodontal disease and thus saving teeth. Thank you, Bob, and thank you, Dawn. A special shout out to Anthony Cannon, an older picture that he sent me showing him with his daughter. And Anthony was the one who has worked with me on developing this presentation and the brochure and so forth. And Anthony requested a professional photo for the brochure. And most of my professional photos are somewhat dated, and I wanted to address this issue in a very unique fashion. So here we go. Here is me as a dental student in 1963. And then in the early 1980s when I published my classification on marginal tissue recession. Then when I was president of the American Academy of Periodontology. And finally the picture that I sent him, which you see in the brochure today. We have a team approach on this, and this is Jonathan Cheney, who is a student about to graduate from the University of Memphis in computer science. Here we are working in the afternoon. We work 3 afternoons a week from about 2 to 6 developing these videos. And here Jonathan and I are giving a seminar, this particular one, on age-appropriate dental. This presentation is based on this article that I wrote in the Journal of Periodontology titled An Evidence-Based Scoring Index to Determine the Periodontal Prognosis on Molars. You can trust the MMPPI because it is evidence-based, it's statistically validated, it's accurate, it has been published, as we pointed out, in the February Journal of Periodontology, and it has been validated because, as you can see here, it won the Clinical Research Award for 2015, and here's a picture of me receiving that award. Now let's talk about how the MMPPI can impact your practice, especially those of you Lenappers who are really into saving teeth. First of all, it markedly motivates patients to accept treatment, to complete treatment, to comply with preventive maintenance, to stop smoking if they smoke, better control blood sugar if they're diabetic, and to initiate lifestyle changes which are so necessary if we're going to have overall health. What makes this MMPPI unique? It's the only index that is quantitative. Number 2, it's the only index that determines prognosis at the initial examination. Now that's important because all of these other studies that we're going to talk about begin when the patient is in maintenance after multiple teeth have been extracted. It's the longest prognosis time in the literature because these patients were a minimum of 15 years post-operative treatment. The average patient was in the study for 24.2 years, and the teeth extracted during the maintenance phase survived for 15.4 years before they were extracted. Here are 10 comparative studies. They all have one thing in common. They began when the patient was in maintenance. This means that a lot of teeth were removed based on the perception of the therapist. Our study, however, started at the initial exam where all molars were scored, even those that were extracted in active treatment before the patients ever got to maintenance therapy. Here's an interesting graphic because it points out one thing that this study pointed out that I think is extremely important. First of all, we can see we use the multivariable Cox proportional ratio rather than a relative risk ratio, because if we'd used a relative risk ratio, the 100 and some teeth, I think 173 that were extracted during maintenance, could not be included in our overall database. The interesting thing here in red, we see that of all the factors scored, smoking was the most significant. But also I would like to point out, if you look at frication involvement, a 1-2-1, the lower the number, the least significant it is. And here we have frication involvement being one of the factors that was least impactful, which points out that we take out too many teeth simply because they have a frication involvement, where these teeth have a good long-term prognosis if they are maintained. Now, let's score a hypothetical case. Because this case addresses a systemic link, it points out the importance of a treatment-focused diagnosis, a TFD, the importance of a lifestyle change, and the importance of periodontal treatment and what it can have on lowering the MMPPI. Now let's look at patient number 2. We call ourselves the physicians of the mouth, so let's see on this patient how that term could possibly apply. The patient's a 29-year-old female, and so therefore she is under 40. We place a dash. She's smoking 2 packs of cigarettes a day, and that's a 4. And she says that she is not diabetic. Her treatment-focused diagnosis is a severe generalized gingivitis with badly swollen tissue, a lot of pseudo pockets, but there really is no attachment loss. Patient's significant clinical findings. Her mother and 3 aunts are diabetic. So not only is there a strong family history, but there is a gender-related significant factor there in that all of these females in the family are diabetic. That should raise a red flag. The next thing is the patient is significantly overweight. So the likelihood that she is diabetic is very real. So what do you do at this point? Do you refer the patient to the physician and lose the patient for a period of time, or do you take action in your office? Then you suggest an in-office A1C be taken. And hopefully you will incorporate this technology in your practice because it is very accurate when compared with a lab A1C and can give the patients an idea of where their blood sugar level is. Here we see the A1C level, and in her particular case, she ends up with a score of an 8.7. Now, in all likelihood, this is very diagnostic of diabetes. However, we as a dentist should never make a medical diagnosis. We should refer this to the physician. But you and I both know that when the patient sees the physician, they're going to come back with a diagnosis of a diabetes mellitus. This is very motivational to patients when they see that we in the dental office can provide this care, and an A1C now doing this test in the office, if you buy these in kits of 10 or 20, it only requires about $12 to $13. So now, having done the A1C in this patient, we find she was an 8.7, so therefore we have changed the diabetes score to a 3. The molar type on the first molar is a 1, and the probing depths are around 5 millimeters, although there is not any attachment loss. This is a severe, tender gingivitis, and obviously you're not going to do a lot of probing at the initial exam. Maybe a spot or 2 in each quadrant to kind of get some feel for what the pocket depths are. And with the gingivitis, you're not going to get a frication involvement, but you do get significant mobility because the teeth that cause patients with diabetes do have a certain level of mobility. So here we're 11, and as we said before, this patient barely has a 50% chance of keeping their teeth, given the severity of the disease and all the factors present. So now let's go ahead and give them a target to aim for. Age remains the same. Smoking goes to a dash. The diabetes, we get this down to 7.2. That's not ideal, but very much improved. So the score is reduced to a 1. Molar type is a 1. The probing depths can actually be reduced by good home care and scaling and so forth to where we have no pockets, no frication involvements, and the mobility is going to be reduced. So we have now reduced her score down to a 3, and she has a 96% chance of keeping the teeth for 15 years. And finally, since smoking was so significant, I have made this smoking cessation counseling video, which I think has proved very motivational. In a recent published study by Dr. Gopal in India on 25 patients that smoked, 3 years later, all the patients had either stopped or cut markedly back, and he credits this particular video for impacting those patients. Now let's see the video. By now you should have reviewed the 2 videos on the Miller-McIntyre Periodontal Prognostic Index, and in that you found that smoking was a tremendous negative impact on long-term prognosis in treating periodontal patients. So I think that everyone in the healthcare profession, especially us dentists, should have some level of smoking cessation counseling. I'd like to say that this is not necessarily scientifically accurate, but it is very clinically practical, and keep that in mind as you watch it. So the patient that we're dealing with is a 68-year-old male, and you can see the smoking score here is a 4. And by treating his disease and taking that 4 out, you can see the improvement of prognosis from a 9 to a 3. So a 75% success rate in keeping the teeth for 15 years, or a 96% for 15 years, basically impacted by smoking cessation as well as the treatment of the periodontal disease. Bill, first of all, I want to thank Dr. Jones for referring you over here for me to treat your periodontal disease. There's been some new research out where we can actually predict how successful periodontal treatment should be. And on a score of that, you have got, if we have treatment, about an 85% chance of keeping your teeth. But there's a fly in the ointment. 4 of that 8 is related to the amount that you're smoking. And we can lower your success rate. We can raise your success rate markedly if you'll stop smoking. Is this something that you would consider?
Well, I don't want to lose my teeth.
Yeah.
But I've smoked almost all my entire adult life. I'm 68 years old. I don't want to lose my teeth, but don't want to quit smoking.
Well, you're about like most of the patients that I treat. But anyway, would you let me kind of give you about a 2 or 3 minutes overlay on that? Because with the data that we have now, if you're a smoker and you have periodontal disease, you have a 243% greater chance of losing your teeth than a non-smoker. Now that's a big number. Mm-hmm. And patients don't realize that smoking impacts the mouth. They know it's bad for the lungs, they know it's bad for the heart, and so forth and so on. So that's why I want to share this information with you. The 243% was some recent research that was published in 2015. So it's fairly new, and that's why most dentists are not aware of it. But what we need to understand is how smoking works. For instance, the major thing, yes, we know about the nicotine, we know about this, but what happens when you take a drag of a cigarette, every blood vessel in your body constricts or narrows. So therefore, the heavy smoker who has a heart attack with narrow vessels has a greater morbidity and dies at a greater rate than a non-smoker. Well, that's on the coronaries. The aorta does that to some degree, but as we come down to the very small vessels called capillaries, the capillaries in the gum, basically what they're doing is bringing oxygen to the tissues. That's what tissues, that's the food that tissues live on. So they constrict, so you're depriving the tissues of what they need to be healthy, as it were. Mm-hmm. But here's what people don't know. You also have little venules, capillaries on the other side, that where you get the exchange in the metabolic products in there, they are exchanged and the bad products are carried away by the little venule capillaries. Well, they constrict as well. So you got a double negative. First of all, you're depriving of oxygen, and then you're poisoning yourself at the cellular level. Now, this is a little bit gross, but it really makes an impact on the patient. If you've got a 3-year-old child and it tugs at his mother's skirt and says, I got to go to the bathroom, what's the first thing the mother says? Number 1 or number 2? Well, what's happening at the cellular level is number 2. So therefore, there's some real reason for stopping smoking. Now, as a healthcare professional, I'm not into smoking counseling, but there's professional help out there by calling 1-800-QUIT-NOW, where you can get counseling 7 days a week, 24 hours a day, 365 days. I'm going to suggest that you call in on it. Do other members of your family smoke?
Yes.
Well, you might just do that together. And I'm not asking you to go cold turkey and quit like this. Most of the patients that I treat, if they're smoking a pack a day, when they come back several months later, they're down to a half a pack. And some of them can go cold turkey, but do whatever is necessary. And if you don't quit, I'm still going to treat you. Your result is not going to be as favorable. I want to have to see you more often. We're going to have to retreat more often. So this will save you a lot of money if you'll stop. Give it a thought. Thank you so much.
Thank you.
Hi, Mr. Burton. How are you today?
I'm doing well. How are you, Carl?
Good. I'm just going to start and take a look at your gum tissue.
Okay.
If you don't mind turning just a little towards me.
Okay.
Very good. Well, I can tell a remarkable difference in the health of your tissue. Have you done anything different?
Actually, I have. Dr. Miller's been, encouraging me to quit smoking, and you have, and I've cut back quite a bit.
Wow, I can really tell a difference.
Not completely. I'm working on it, but it makes me feel good that my dental health looks better. And
That's
you can
great.
tell that much.
I can. There's a lot less bleeding from the last
I've
time.
noticed that. So
Wonderful.
I'm still working on it, but I'm getting close.
Oh, that's great. That is great.
The video you have seen is not scientific, as we pointed out on the front end. It is, however, very effective if it is done in the proper fashion. But what do we mean by the proper fashion? We're here to provide facts that the patient can understand and let them see how negative smoking is on their long-term prognosis. But you need to be patient. You'll notice this patient 6 months later had not completely quit, but was on the road to quitting. We need to be patient and let time work, and eventually many patients will stop smoking, and this may be even more important than the periodontal treatment that we render.